I want to welcome everyone to the forum on reviewing the role of pharmacy benefit managers in pharmaceutical markets. Today's proceedings are being live streamed at the GOP Oversight YouTube page, and we've been very pleasantly surprised with the amount of interest we've had from all over the United States about this hearing and this topic. I recognize myself for as much time as I consume. Americans spend more on prescription drugs, about $1,200 per person, than any other country. While prescription drugs account for approximately 10% of overall healthcare spending, Americans pay more out of pocket for prescription drugs than for hospital care or health insurance. For years, Democrats have attacked pharmaceutical companies that bring innovative and life-saving medication to market, including 3 incredibly successful COVID-19 vaccines, thanks to Operation Warp Speed. Instead of highlighting successful pharmaceutical innovation that leads to treatments and cures for disease, Democrats have demonized these companies for high list prices without regard to the fact that patients do not pay the list price and patients can still access the medication. All the while, Democrats have given a free pass to pharmacy benefit managers, even though they play an outsized role in driving rebates and list prices of prescription drugs. Despite my request to Chairwoman Maloney to hold a hearing to examine the role of PBMs, Democrats have decided to limit their drug pricing investigation to only pharmaceutical companies, leaving a significant void in the Oversight Committee's review of drug pricing and many unanswered questions. And I just want to reiterate what I've told many of you. At the beginning of this Congress, Chairwoman Maloney and I sat down and I thought, had an agreement to hold at least 3 bipartisan hearings in the House Oversight Committee. And one of the hearings that I thought we agreed to have was going to be what we're doing today on PBMs. But apparently the wheels have come off in the House of Representatives, and there's no interest in the majority party to have any type of bipartisan oversight hearing. So here we are today. I'm very pleased to hold this forum to examine the role PBMs play in pharmaceutical markets. PBMs were intended to be intermediaries to negotiate with pharmaceutical manufacturers, insurers, and pharmacies on behalf of public and private payers such as Medicaid and Coca-Cola, for example. Over the past decade, PBMs have consolidated from more than 20 regional and national players to just 3 that control roughly 80% of the market. The consolidation in the market has enabled PBMs to exercise significant negotiating power with pharmaceutical manufacturers and led to increases in the use of generic medications and savings for patients. However, PBMs have not only consolidated horizontally, they've also done so vertically. As of today, every major PBM owns or is owned by a major health insurer. Furthermore, every major PBM owns or is owned by a specialty mail order or retail pharmacy, or all 3. This means that when PBMs negotiate with a pharmacy or a health insurer, they are either negotiating with themselves or one of their direct competitors. Their position as the middleman, negotiating and engaging with all the players in the pharmaceutical market, has enabled PBMs to grow exponentially and snuff out their competition. PBMs audit competing pharmacies, viewing data including the pharmacy's acquisition costs and patient data, and then use that data to steer commercial patients to their own pharmacies and reimburse competing pharmacies at lower rates. In Ohio, 2 of the largest PBMs, CVS Caremark and Optum Rx, charge Ohio Medicaid $223 million more than it had paid competing pharmacies. In my home state of Kentucky, PBMs paid competing pharmacies $123.5 million less than was charged to the state Medicaid program in 2018 alone. This is only one example of how PBMs negatively affect competition. In the Medicare program, PBMs use a tactic known as direct and indirect remuneration, or DIR, to claw back billions of reimbursements paid to pharmacies. In 2019, DIR clawbacks rose to over $9 billion, more than 18% of the Medicare drug spending. While these Clawbacks were originally intended to enable PBMs to accurately report pharmacy rebates and price concessions. They have grown dramatically, enabling PBMs to create a negative reimbursement in certain cases. This means a PBM is not only taking back all of what the PBM paid the pharmacy for the prescription, but also clawing back all or a portion of the patient's copay. PBMs also exert immense control over patient formularies, allowing them to steer patients to high-cost medications because these medications give them higher rebates. By steering patients to higher-cost medications, PBMs increase patients' copays and force manufacturers to increase list prices to pay PBMs higher rebate demands. While PBMs pass on a portion of rebates they receive to payers, their lack of transparency makes it nearly impossible to determine whether these rebates are truly benefiting patients or simply increasing PBM profits. Without greater transparency of PBMs, it's difficult to see how these tactics are benefiting patients at all. If the value for consumers is so great, it shouldn't be a stretch for PBMs to prove their worth and have an open discussion about their practices. That's why this forum is so important today. Today, we take a first step to reviewing the role of PBMs in pharmaceutical markets to determine what, if any, changes need to be made and how proposed legislation could decrease the cost of prescription drugs and patient benefits. Now, I would love to introduce our very impressive panel here today. Dr. Jonathan Grider is a pharmacist and owner of Lake Cumberland Pharmacy in Russell Springs, Kentucky. Dr. Erin Trish is the co-director of the University of Southern California Schaefer Center and assistant professor at the USC School of Pharmacy. Mr. Antonio Chacha, did I pronounce that right? CEO of 46 Brooklyn Research and president at 3 Axis Advisors. Dr. Madeline Feldman, president of the Coalition of State Rheumatology Organizations. Mr. Kim Caldwell, principal of Texas Star Healthcare Consulting, testifying on behalf of the Pharmaceutical Care Management Association. Ms. Tiffany Jones, vice president of regulatory and compliance and assistant general counsel at Sendera RX Specialty Pharmacy. Now I want to recognize my friend, Mr. Keller from Pennsylvania, to introduce our final witness.
I thank the ranking member, and it's my pleasure to be able to introduce from Pennsylvania's 12th Congressional District, Uniondale, Pennsylvania. Mr. Ted Okun is the executive director of the Community Oncology Alliance and someone with whom I've been able to work on addressing this important issue. Thank you to Ted and all of our witnesses for being here with us today.
Thank you, Mr. Keller. Now, our witnesses will have 3 minutes to provide their opening remarks, and we're going to begin with Dr. Grider, who is going to testify virtually.
Ranking Member Comer and members of the committee, thank you for this opportunity to share my perspective on the impact that PBM practices have on small business pharmacies like mine. My name is Jonathan Grider, and I am a third-generation pharmacist. I own Lake Cumberland Pharmacy, which today has 2 locations in Russell Springs, Kentucky, and I am also a partner in St. Matthew's Specialty Pharmacy located in Louisville. PBMs play an oversized role in federal healthcare programs as large corporate middlemen. PBMs determine which pharmacies patients may choose by creating provider networks, determine which drugs patients can be prescribed by creating drug formularies, and determine how much patients pay at the pharmacy counter for their medications. Because of their anti-competitive practices and our nation's ever-increasing drug costs, greater scrutiny over PBM business practices is imperative. Approximately 80% of my patients are covered under Medicare and/or Medicaid, and this disproportionate share of my business revenue coming from federal healthcare programs is not uncommon for pharmacies like mine in underserved communities. Today, I wanted to highlight 3 areas of concern regarding PBMs and some potential solutions. First, Congress should address the vertical integration in PBM marketplace. Today, the 3 largest PBMs control 77% of the health plan pharmacy benefit market. With their limited regulation, PBMs set the rules that pharmacies must follow, have the upper hand in negotiations, and can force pharmacies into take it or leave it contracts. PBMs steer patients to their affiliated retail, mail order, and specialty pharmacies, and many times mandate patients in certain plans to only utilize the PBM affiliated pharmacies, therefore depriving patients of any choice. These ownership interests raise conflict of interest questions and continue to lead to decreased competition and fewer choice for patients. Congress should pass the Prescription Pricing for the People Act of 2021, which would require the Federal Trade Commission to review the consolidated PBM industry and their anti-competitive practices. Second, Congress must finalize pharmacy DIR fee reform. CMS documented a 91,500% increase in DIR fees paid by pharmacies from 2010 to 2019. By comparison, if a gallon of milk increased by the same percentage over the same time period, it would cost $366 a day, and gas would be roughly $2,700 per gallon. These fees, which lead to higher costs for beneficiaries at the pharmacy counter, put them at risk for reduced medication adherence and poor outcomes. Finally, Congress should ban the practice of spread pricing in Medicaid managed care across the country. In 2020, Kentucky passed Senate Bill 50, which I worked on with Senator Max Wise and former Medicaid Director Justin Joseph. The law requires a state to contract with a single PBM to administer Medicaid managed care benefits and authorize the Medicaid department to establish pharmacy reimbursement methodologies and dispensing fees. On behalf of the community pharmacies across America, I appreciate the diligent work of this committee to examine the anti-competitive practices of PBMs and their impact on patients and pharmacies.
All right. Thank you very much, Dr. Greider. And I now recognize Dr. Trish.
Thank you. Ranking Member Comer and other distinguished members of the House of Representatives, thank you for inviting me to speak with you today. My name is Erin Trish, and I co-direct the Schaefer Center for Health Policy and Economics at the University of Southern California. The Schaefer Center strives to measurably improve value and health through evidence-based policy solutions, research excellence, and public and private sector engagement. As part of this mission, my colleagues and I have been studying prescription drug pricing and PBM activities for over a decade. PBMs, which operate in the middle of the pharmaceutical supply chain, play an important role in drug pricing. PBMs, as you know, manage drug benefits on behalf of health insurers and employers. Historically, they were independent from health plans and added value by negotiating better prices, encouraging uptake of generics, and expanding mail order services. However, a wave of consolidation in the last few years, including health insurers buying up PBMs, as you mentioned, and other activities have distorted PBM behavior. As a result, patients are being left behind. Perhaps the most egregious policy concern is the increased use of hidden rebates. Rebates drive a wedge between a drug's list price and its net price, or the amount the manufacturer actually receives. Our research on Medicare Part D shows how pervasive the issue has become. Rebates in the program have more than doubled over the last decade. While this has helped keep premiums low, it means beneficiaries pay more out of pocket at the pharmacy counter. The incentives are particularly perverse. Beneficiaries pay the most for drugs that face the most competition, where rebates tend to be the largest. These distortions not only harm patients, but they also obfuscate the bigger drug pricing issues. Insulin is perhaps the most salient example. Recent research by the Schaefer Center, led by my colleague Professor Karen Van Nuys, found that while total expenditures per unit of insulin remained relatively stable from 2014 to 2018, manufacturers are getting paid less for insulin year over year. The share of insulin spending captured by PBMs increased 155%. In fact, less than 50 cents of every dollar spent on insulin goes to manufacturers. Instead, the majority gets siphoned away by intermediaries in the supply chain. We have also showed that PBMs overcharge for generic drugs. My colleagues and I recently compared the prices that Medicare Part D plans pay for common generic drugs with the prices at Costco. Buying these drugs at Costco would have saved Medicare, or could have saved Medicare, $2.6 billion in 2018 alone. So, while there is robust competition among generic manufacturers for these common drugs, the PBMs and other intermediaries have figured out how to keep the benefits of competition from reaching beneficiaries and taxpayers. Some simple reforms could improve the system, and I refer you for more detail to my written testimony. Broadly, these involve requiring greater transparency, encouraging competition, and better aligning incentives. I look forward to the discussion about these issues today. Thank you.
Thank you very much, Dr. Trish. Mr. Cha-Cha.
Members of the committee, my name is Antonio Chacha, CEO of 46 Brooklyn Research and president of 3 Axis Advisors. Simply put, I study prescription drug prices all day, every day. And I can tell you that drug pricing is really complicated, and we know why. With mystery, there's margin, and there's a lot of mystery. Unfortunately, when we talk about the price of a drug, the actual price evades us as consumers. That's because there are many ways to quantify the price of a drug, and whatever price we are quantifying can be different depending on who exactly is experiencing the price. Regardless, whether a drug has 2 prices or 64 prices, anytime you have more than one price, you have no price. The lack of objectivity enables and empowers those who seek to take advantage of government-sanctioned and market-yielded latitude on drug price management and architecture. In my home state of Ohio, we've learned a lot about PBMs, thanks to vocal pharmacists, thorough investigative journalism, and a relentless pursuit of accountability from state lawmakers, State Attorney General Dave Yost, and Governor Mike DeWine. Years ago, pharmacies of all shapes and sizes complained that within our Medicaid managed care program, PBMs had slashed reimbursements to the point where as much as 80% of the gross margin had evaporated. Hundreds of pharmacies across the state were closing, in large part due to the unprecedented cuts. In a long, drawn-out search for answers through our own CMS drug pricing data, the work of the Ohio Joint Medicaid Oversight Committee and the Columbus Dispatch, it was revealed that the cuts to the pharmacies never resulted in savings to the state. Through the discovery of audits, we learned that PBMs were taking advantage of the latitude to arbitrage prices in the program through a practice known as spread pricing, where the PBM pays the pharmacy low, bills the plan sponsor high, and pockets the difference. In our case, that spread was $244 million in just 1 year of the program, which is anywhere from 3 to 6 times the going rate for PBM services. Our state banned and sued one of the companies engaging in the practice, but the problem of overinflated prices was never fully extinguished. Last month, the Ohio Medicaid director revealed that the state's drug pricing data, as well as drug pricing data for other state Medicaid programs, is likely corrupted and untrustworthy due to the recent PBM maneuvers to further obfuscate the reporting of true net costs to the state. This is bad news for you all as well, as these prescription drug overcharges are not unique to Ohio, not unique to Medicaid, and all the pumped-up drug prices are matched with federal taxpayer dollars. That said, not all PBMs engage in this type of these costly tactics, and PBMs are not the only layer in the drug supply chain that include bad actors that seek to exploit their trusted roles between patients and their medicines. Our longitudinal research has shown that pricing arbitrage is a universally adored activity among drug channel participants, but as PBMs bill themselves as the only member within it working to lower prescription drug costs, and as they set the incentives for the rest of the drug channel, it is imperative that PBM accountability be a central component of any endeavor aimed at lowering prescription drug costs. Financial incentives are what drive industry behavior, and the excessive complexity of the U.S. drug pricing, the lack of transparency, and the significant conflicts of interest within the drug channel sadly create unlimited opportunities for gamesmanship and unwarranted cost inflation. More simply put, if you don't like what you see as the outcome of the current drug channel, you must target a recalibration of the incentives and those who create those incentives if you are ever going to change future output. It is for that reason that any serious attempt at solving America's unique drug pricing dysfunction will inevitably fall short if the subjective price setting, pervasive opacity, arbitrary margin distribution, and misaligned conflicts of interest that plague the predominant sectors of the PBM industry today are not addressed. Thank you very much for the invitation today.
Thank you, Mr. Cha-Cha. And Dr. Feldman.
Thank you for having me here. I'm Dr. Madeline Feldman. I've been in private practice in New Orleans in rheumatology for about 30 years now. I'm going to just start with some examples of how our broken system is affecting formularies, pricing, and one in particular, my patients. There are 3 rheumatoid arthritis drugs that are in the same mechanism of action. One is $30,000 a year, one is $65,000, and one is $75,000. Guess which drug cannot get onto the formulary? Yes, the $30,000 one. We have a drug pricing crisis, really? Number 2, there's a drug to treat metastatic prostate cancer that costs $10,000. About 3 or 4 years ago, a $350 generic was made. Only the $10,000 one at a very prominent PBM is even allowed for the employer to even use. The $350 generic is excluded. The doctor can appeal, the patient can get it, but it's going to cost them more than the $10,000 drug. I'd like to talk very briefly about biosimilars, supposedly the great hope of bringing down the prices of the biosimilar. We all know the interchangeable biosimilar for insulin came out a week or so ago. Only the high-priced one can be on the formulary. PBMs are paying patients who are stable to switch to more profitable drugs, and this, I think, is really criminal. Finally, we're going to have a test that will predict rheumatoid arthritis patients will respond, what drug they'll respond to. There's an entire class. Unfortunately for the PBMs, it is the most profitable class of drugs on the formulary. And I think we all know what drug that is for rheumatoid arthritis. This test would allow the patients to hop over that. One of the major PBMs is trying to disincentivize employers from letting patients get that test. If rheumatoid arthritis patients are not treated adequately and quickly, the joints are destroyed, leads to heart attacks and lymphoma. That should be criminal. It all boils down to the formulary. If you are an expensive drug, if you ain't on the formulary, no one's going to take your drug. I'll be happy to give you the exact example how competition raises prices. I can't tell you how many times I keep hearing competition, competition, competition. It's obvious why PBMs don't want transparency. First thing they do, reclassify rebates as fees so they're not passed back to the client. Second, vertical integration, a bigger black box. And most recently, rebate aggregators. These are contracting entities of which 2 of them are offshore. So if legislation is passed for transparency or rebate pass-through, the definition of where that money is going now must include that or you're going to lose it altogether. Rebate aggregators. Let's build a system that doesn't create a race to the top of drug prices. Let's face it, everyone in the drug supply chain makes more money when the list price goes up. Everyone benefits except for the patient. We need, and it's the patient supposedly that our healthcare system is here to help. Thank you.
Sorry
Because that's my time to shut up.
Well, thank you very much, Dr. Feldman. It's very concerning that the Democrats want to hold hearings and oversight about drug pricing, but don't want to address this issue. Very, very, tells a lot. Mr. Caldwell.
Good morning. I'd like to thank Congressman Comer for hosting this forum. My name is Kim Caldwell. I am a pharmacist with more than 45 years of experience working across the pharmacy supply and payment chain. I have owned and operated an independent pharmacy, have worked for chain pharmacies, large prescription drug manufacturers, and health insurers. Additionally, I served at CMS helping the Bush administration write the initial program rules for the Part D drug benefit. I am here today on behalf of the Pharmaceutical Care Management Association, the national association representing America's pharmacy benefit managers, PBMs. Much like hospitals, universities, large research organizations, and even Congress, PBMs are entities which are staffed by bright, caring, and creative individuals who take their jobs and responsibilities seriously and who earnestly want the best outcome for patients, beneficiaries, and the healthcare system. PBMs are contracted to perform services for their clients that are directly related to the administration of their clients' prescription drug plans. The clients include health insurance plans, self-insured employers, labor unions, and government plans such as Medicare Part D. The functions, expectations, and accountabilities of the PBM are directed and audited by the clients. As its centerpiece for the delivery of the pharmacy benefits, PBMs have come under scrutiny less because of who they are, but more because of the spotlight on the cost of prescription medications. PBMs do not set the price of prescription medications, nor do they control the price increases for those drugs. However, PBMs drive and hold down the cost of prescription drugs to assist payers in the quest to keep premiums and out-of-pocket costs manageable for their members in the healthcare system. In addition, PBMs maintain a seamless system that provides on-the-spot adjudication of pharmacy claims so patients know their cost sharing, for example. Finally, as the private sector backbone of the Medicare drug benefit, ensuring that the plans are designed around market principles and ultimately around the beneficiary value, PBMs are actively engaged in the ultimate goals for their clients' membership. Get sick members well, well members healthy, healthy members become more active, and these goals align with the care management part of PCMA. Thank you for allowing me to participate today.
Ranking Member Comer and members of the committee, thank you for hosting today's forum on the role of PBMs. I'm grateful for the opportunity to discuss the important role of specialty pharmacy and my experience working with Sendera, a national independent specialty pharmacy treating diseases like rheumatoid arthritis and multiple sclerosis. Specialty pharmacies support patients who have complex health conditions, and the medications they dispense are typically expensive. Specialty pharmacies provide training in how to use medications, comprehensive treatment assessment, ongoing monitoring, and frequent communication with the patient's physician or other healthcare providers. Many specialty drugs need to be injected or infused at a doctor's office or hospital. Specialty pharmacies' expert services drive adherence, proper management of medication dosing and side effects, and ensure that costly drug therapies and treatment regimens are used correctly and not wasted. While the number of specialty drugs only comprises 2% of the total number of prescriptions dispensed in the U.S., it represents nearly 50% of all drug spend. Distribution for most specialty drugs is limited, with payers working to keep them even smaller. The market is heavily dominated by the largest PBMs and the insurers that own them, and as the market has grown, so has vertical integration. Insurers have more financial incentive to fill a drug through their PBM-owned specialty pharmacy and have conflicts of interest in doing so. The impact on pharmacy access for patients and the cost of the healthcare system as vertical integration persists is dire. Far more regulatory oversight is necessary with specific protections in place to ensure that pharmacy networks include a robust network of specialty pharmacies for patients, the practice of patient steering is prohibited, and pharmacy DIR clawbacks on pharmacies are eliminated and prohibited. Sendera constantly witnesses efforts by PBMs to limit independent pharmacy participation in networks. They often demand impossible participation terms and non-negotiable reimbursement rates that do not even cover the cost of the drug, much less the required services. Impossible terms could include requiring a pharmacy to stock unnecessary non-specialty drugs and mandating that a pharmacy set up a new physical location despite no need for such requirements. Sendera and other specialty pharmacies continue to work through state and federal law to get into networks, but even if pharmacies are initially successful, PBMs often steal the prescriptions back from the pharmacy using patient steering. Insurers and PBMs that are integrated can see a patient's insurance information and use that to contact a patient or a prescriber, instructing them to transfer their prescription to the PBM's own pharmacy. Sick and vulnerable patients are threatened that they will lose coverage for their drug if they don't comply. Without federal oversight, network pharmacies continue to fall victim to these anti-competitive practices, and patient access to pharmacies is lost. An anti-market practice contributing to high Medicare drug costs is through PBM use of direct and indirect remuneration fees, or DIR fees. DIR fees are monies received by PBMs and plans that include concessions PBMs force pharmacies to pay long after the pharmacy dispenses the medications. The fees are not used by PBMs or their affiliated plans to reduce the cost of drugs for seniors. DIR fees are not transparent and only result in profit for the PBMs, forcing pharmacies to fill Medicare prescriptions below cost. CMS reported to Congress this year that DIR fees on pharmacies have increased by 91,500%. That's right, more than 91,000% between 2010 and 2019. Sendera has seen a reduction in staffing and loss of patient access as a result of millions of dollars of DIR fees paid every single year. If all pharmacy DIR fees were assessed fairly and transparently at the point of sale, patients would see immediate reduction in their drug costs. We are grateful for the leadership of committee members to introduce and support H.R. 3554, the Pharmacy DIR Reform to Reduce Senior Drug Costs Acts. This bill addresses pharmacy DIR reform that is needed this year. Thank you.
Wow. Thank you, Ms. Jones, and Mr. Oken, you're now recognized.
Thank you, Ranking Member Comer. My Congressman, Mr. Keller, thank you for the kind introduction. I thank you all for the opportunity to share my views on PBMs. I'm the Executive Director of the Community Oncology Alliance, a nonprofit organization dedicated to cancer patients and their oncologists. It is difficult in my brief opening remarks to describe to you the significant destructive impact PBMs have on cancer care and their role in fueling drug prices for Americans. But I will quickly summarize the toxic influence of PBMs, and I'm happy to answer any questions. You need to understand that the PBM market is drastically consolidated such that the top three PBMs, CVS, Express Scripts, and OptumRx, control upwards of 80% of the prescription drugs in this country. Consolidation hasn't stopped there, as these PBMs are owned by the top 1, 3, and 4 health insurers. With this near stranglehold on medicine, these companies can dictate what cancer care an oncologist can prescribe and how and where cancer patients receive treatment. PBMs and their corporate insurers use a variety of tactics such as step therapy, formularies, and rebates to dictate treatment decisions by restricting access to optimal drug therapy to ensure the most profitable drugs to the PBM/insurers are given. Then, especially in the case of oral cancer drugs, they dictate that patients obtain their drugs via the PBM's mail-order pharmacy rather than at the point of care from patients' providers. Not only does this disjoint and uncoordinate the patient's care, but it leads to delays, denials, and waste. As if this weren't bad enough, PBMs extract rebates, some would say extort, from drug makers,
I'm not letting drug makers off the hook here and try to buy their way into formularies by offering rebates to PBMs. However, the leverage of the large PBMs is such that they can demand increasingly greater rebates from drug makers, or their drugs don't see the light of day on formularies, or in a recent case, pay a near 50% rebate of the drug, or the drug will be declared medically unnecessary. As rebates have come under pressure from employers and governments, PBM have turned to pharmacies, either freestanding or, in our case, associated with an oncology practice, to extract what have become known as DIR fees under Medicare Part D. These arbitrary, nebulous fees collected 3 to 6 months after a drug is dispensed cause drugs to be reimbursed less than cost, which is why so many independent pharmacies are going out of business. However, because of rebates and DIR fees, PBM have a vested interest in having drug list prices be as high as possible. Although drug makers set the price where too high, which is often too high in cases, PBMs make money by fueling them higher for Americans. I will never forget sitting in Senator Cassidy's office with a sister and a brother from Louisiana relating how their mom fought the PBM for 2 months to get her cancer drug, which she would have gotten immediately from her oncologist. A week after being admitted to hospice, their mom finally got her drug, but a week later, she died. As the daughter related through tears, we don't know if the drug would have saved her, but the PBM robbed her of hope. No cancer patient should be robbed of hope by a PBM. Thank you for listening.
Thank you very much. Very impressive opening statements by our very impressive panel. We're going to go into the question phase, and then we'll go from there. One of the things that the Oversight Committee is going to do, especially the Republicans, we're going to provide oversight. If you've kept up with the hearings that the Democrats have had, the topics have been all over the board, and with all the problems in America, it's always a treat to see what subject that the Democrats propose to hold a meaningless hearing on. This is a real issue in healthcare. Healthcare is one of the most important issues that Congress addresses, and I just think that this is going to be a very productive hearing based on the opening statement. So diving into the questions, I'll begin. My first question is for Dr. Greider. Community pharmacists like yourself work the front lines in our healthcare system in Kentucky and rural America. I know during the pandemic, you all were the first to provide COVID vaccinations and help many Kentuckians. Yet during that same time, you were having to pay DIR fees at all of your pharmacies. Now, how much did PBMs force you to pay back in 2020 during the pandemic?
Ranking Member Comer, I think to better answer that question, I first need to give the committee members a snapshot of the community that you and I both serve. Russell County is located in South Central Kentucky, has a population of roughly 15,000 individuals. That county is mostly made up of Medicaid and Medicare recipients. As I mentioned in my opening statement, roughly 8% of my business falls under this category, with the 60-40 split between Medicaid and Medicare recipients respectively. As I mentioned, I have 2 locations in the community. On average, both of my stores combined fill roughly 500 prescriptions per day, Monday through Friday. In terms of prescription volume, this probably ranks among the 50th percentile, slightly lower as compared to state and national averages in terms of pure prescription volume. Based off these numbers, I fill roughly 40,000 prescriptions per year to the Medicare Part D. Living in rural Kentucky, we have roughly a high incidence of diabetes, hypertension, COPD, and cardiovascular disease. Not to mention the increasing rates of opioid misuse, substance abuse, hepatitis C rates since COVID-19. With these disease states and the formularies used and set by the PBMs, the vast majority of these 40,000 prescriptions are filled with brand name medications. So with that said, I was able to go back and calculate in 2020 alone, we paid roughly $137,000 in DIR fees. In 2019, we paid roughly $92,661. And currently, as of right now in 2021, we're on pace to pay $145,000. I also have ownership in St. Matthew's Pharmacy. I was able to extrapolate their DIR fees for 2020, and they paid roughly $1.1 million in DIR fees. They fill roughly 100 to 150 prescriptions per day, predominantly brand name products since it is a specialty pharmacy. To even extrapolate those numbers further, I sit on the board for Epic Pharmacies, which is a PSAO, Pharmacy Services Administration organization. We roughly have 1,300 independent pharmacies like mine across the United States in our group. Since 2019, we've had 129 pharmacies close the door or either sell to the chain pharmacy. In 2020, our group paid $67,523,000. As of right now, in 2021, we're on pace to pay $86 million. With that said, I first want to apologize, Ranking Member, and to the members of the committee for not being able to attend this roundtable discussion. Subject matter is of great importance to me and my colleagues. However, due to the thousands of dollars, as you can see, paid back each year, pharmacists like myself are backed into corners that we must face difficult business decisions each day to cut our cost. So once this discussion is completed, I'll be back at the pharmacy making PBMs some more money.
Well, that's an excessive amount of money that would be devastating on any business, and I hear that from all my independent pharmacies all over Kentucky. Last question, why don't you just leave the PBM network, Dr. Grider?
That's a great question, one that keeps getting brought month after month with conversations with my colleagues. First off, pharmacy owners like myself who live in these rural areas, most have Medicaid, Medicare. As of 7/1, we kind of got the Medicaid situation fixed where we allow only one PBM to manage our state Medicaid. However, the state manages that. They set the methodologies, leave it up to the Medicaid and create the formularies. So we've got control, a little bit more transparency with that. However, with the Medicare Part D, a lot of these are take it or leave it contracts that we must sign. A lot of times the PSL will sign those contracts on behalf of the pharmacy group. We never get to see those. And there really isn't any negotiation that takes place with these contracts. The PBMs could care less if the pharmacy signs a contract or not. If they do, they will profit from the Dir fees collected, as you can see. If they don't, then they'll just push these patients to their own pharmacies or to their mail order pharmacies. They set the rules, they set the terms, they set the reimbursement rates. So bravo to them, to such a great business model.
Well, that's, we feel for you, and I know that several on this panel have heard from many similar comments from your colleagues in the independent pharmacy business. I just want to ask one last question, Mr. Caldwell. We just heard a real example of what the PBMs are doing with respect to pharmacies and Dir fees. The lack of transparency around these fees means pharmacies can and do lose money every time they fill a prescription. What are PBMs doing to address this issue, and are they open to greater transparency with their Dir fees?
Congressman, I'll respond first by saying, no, you didn't hear necessarily what PBMs are doing. What you heard was how one pharmacist owner is looking at his business, and I appreciate where it is because I've been a pharmacy owner. I look at things out there, and we're not getting a full definition of what he's calling Dir fees because there are numerous things that are out there. Some of the contracts will have, at the request of pharmacies, and I remember in 2012 when I stood in front of NCPA and the National Association of State Pharmacy Associations explaining they wanted to have the right to prove that they could provide better adherence, and they wanted to drive it for things that plans, especially in Part D, would be around diabetes and hypertension and statins and all the appropriate. They said, we can do it better than you can, and we're willing to take risks to do it. And so contracts were put out there at risk where they had an opportunity to make money, or they had an opportunity to stay where they were, or maybe lose money if they didn't perform. And those are Dir fees according to the law.
So,
and so,
well, I don't doubt that that's the law. That's one of the things that we're going to be probing to determine whether the law needs to be changed. I mean, I hear this from every independent pharmacy in Kentucky, and I guess what you're trying to say, with all due respect, is the PBMs are being transparent with those Dir fees?
it's not necessarily the PBM. PBMs is the one who does work on behalf of their client. It could be a health plan, it could be an employer, it could be someone else that has determined how they want it to go. The PBM is the one that works on the contracts. They offer typically 2 sets of contracts. They will have preferred network contracts where those pharmacies get paid less, but the beneficiaries that go to them pay us lower copay, or the standard, and they'll open that up to any pharmacy that wants to accept those terms as listed. And that's the standard that is provided for health plans, the PBMs, and all that, especially in Part D, because of Social Security Act. It's established for them to put those in place, and they set those aside, if I can. But he mentioned PSAOs, and he said, well, I guess they sign those, don't they? The pharmacies choose to be part of a PSAO. They don't have to be. That's something that they do on their own. If they don't know what the contract is, if they don't know what the PSAO is signing for them, maybe they shouldn't be with that group. They should be with someone else.
Well, we look forward to discussing this issue further, and my time is up, and now we yield to Mr. Keller from Pennsylvania.
I thank the ranking member, and I thank all the guests for being here today. You know, from community pharmacies to healthcare providers to patients using a Medicare Part D plan, price transparency is an essential issue, not just in northeastern or north central Pennsylvania, but all across our nation. And it's been the case for too long. Pharmacy benefit managers play a significant role in the drug pricing debate with certain anti-competitive tactics that raise patient costs at the pharmacy counter and claw back hundreds of thousands of dollars in Dir fees from pharmacies months after drugs have been dispensed. That's what we're hearing when we're talking to people all across, that I encounter all across Pennsylvania. It makes it difficult to operate these small businesses and making it more difficult for providers to deliver health care. CMS has determined that there was a 91,500% increase, and I heard that in the testimony, in Dir fees between 2010 and 2019. This unacceptable growth of Dir fees creates access issues to many seniors in Part D and increases the possibility of pharmacy deserts across Pennsylvania and the United States. CMS also anticipates that the average growth of pharmacy Dir fees will increase roughly an additional 10% per year. And by taking action, we can help save America's seniors up to $9 billion out-of-pocket costs. Now, there's a couple things that came up, and I guess I'd like to just follow up on that. And I'd actually like to ask Dr. Greider a question regarding up to how much time can it be till you'll know when you're going to have a Dir fee clawed back from something you've prescribed or filled a prescription of?
So Dir fees are point-of-sale clawback fees that are associated months after the Part D prescription and the patient's picked up the meds. On average, you're looking at 6 to 8 months. Back to what Mr. Caldwell said, the PSAO is there to help offset and to account for the Dir fee. If I'm going through my daily life, filling scripts and not keeping up with the Dir fee, and then 6 months down the road, get hit with a $60,000 check that I must pay back to the PBM, why it would force me to shut my doors that day.
So are you aware of what the Dir fee might be when you fill the prescription, or is this something that is part of your contract, or how's that calculated?
So the Dir fee is calculated by, Mr. Caldwell said, the metrics that were set in place 6 months down the road. So right now I'm being assessed a Dir fee on the performance my pharmacy performed 6 months ago, which was during the height of COVID. And so back to the point, not only am I just the pharmacist in charge, I'm the CFO of the pharmacy, the CEO, the COO, HR, IT, marketing. So we wear several hats. And so sitting here trying to figure out, A, what a Dir fee is going to be, I would A, need to hire a mathematician to figure it out, or B, become a mathematician, or C, just rely on our PSL to help guide us to those areas. Okay,
it seems like it's really a difficult thing that could use some transparency, and I would see what we need to do there. And I guess my next question is for Mr. Oken. How do Dir fees under Medicare Part D impact patients and clinics?
Well, the biggest thing you have to understand, Mr. Keller, is on the patient side. Basically, the PBM has a vested interest in the drug price being as high as possible. They're extracting the rebate or extorting the rebate off of that. And in addition to that, the Dir fee, in our case, and what I'm saying is that given that 30 to 40% of oncology drugs are now in oral formulation, the PBMs have discovered a very lucrative market. And so they have a vested interest of that DIR fee being as high as, DIR fee off of the list price of the drug, that being as high as possible. So the problem is the patient is paying off the list price. The patient isn't paying off the net. And I just want to say one thing, and I've submitted this in written testimony. This is literally from one of the top PBMs, and it shows the DIR report. I defy any of you or anybody to understand what this report is. 6 to 8 months after the fact, you're basically assessed DIR fees, and you have no idea. And in our case, in oncology, we are partly literally judged on ACE inhibitors and drugs that don't have anything to do with oncology. And it really is a shame, because it's ultimately the patients who are paying higher off of list prices.
Okay, thank you. I appreciate it. I see I'm out of time now, but I appreciate the opportunity. I appreciate your testimony. Thank you.
Thank you, Mr. Keller. Now recognize Mr. Franklin from Florida.
Thank you, Ranking Member Comer. I really appreciate this hearing today. Having sat through things as a freshman here the first 11 months, this is the most meaningful and relevant hearing we've had yet, and it just appalls me that it's only Republicans here today, because this is something that is really near and dear to all of us. I spent the last 20 years before coming to Congress in the insurance business. I was a retail insurance broker, representing companies out there that are just trying to do the best for their employees and individuals trying to get health care if they weren't fortunate enough to have a company that provided it for them. And I would tell you that our system is broken. If we were going to be fair and honest, Mr. Caldwell, the PBMs are on the hot seat today, but we could just as easily be having physicians groups, plaintiffs' attorneys, insurance companies, you name it. Everyone should be dragged before the microscope, because the reality is we've got a system that, while we provide some of the best health care in the world, we've got the greatest research, we spend a staggering amount of money and we don't get our money's worth, candidly. And Mr. Chacha, you said something today that I wrote down. I always love a good quote, and I've never heard that. Where there's mystery, there's margin. I can't think of any other part of our lives shrouded in more lack of transparency and secrecy than what happens in the medical world. And where else do we make a purchasing decision? We go to the doctor. The bill shows up in the mail later. I couldn't tell you how many zeros are going to be on that bill. It's hard, even as a person in the industry, to know what's covered, and the patients are the ones that are getting the short end of the stick. But Mr. Caldwell, just a quick question for you. Do PBMs direct patients to use certain medications in order to receive larger rebates?
Thank you, Mr. Franklin. The answer is no, and I will give you a variety of things that are out there that relate to that. One, the rebates that come through that PBMs negotiate on behalf of their client, in virtually every case, and I'll explain the virtually part, virtually every case are 100% passed through to their client. However, they may keep some of it if that's what their client said they wanted as their way of paying for PBM services. But it's the same dollar. And in Part D, where the biggest amount of rebates are, because that's the one part of the whole system that is not crushed by Medicaid best price, and to me, Medicaid best price means somebody else is paying a worse price. But in Medicaid best price, in the commercial side, there is a limit of the amount of rebates that can come through and be passed to try to lower premiums and try to drive down costs. In Part D, it is not there. So it's a great amount of rebates, but they get passed through. There is no direction to make someone go get a product just because of the rebates that are going to come in or the price that's out there. On another hand, let's look at the healthcare dollar as we spend it today. Prescriptions, everything tied to prescription counts for 21.5 cents of that dollar. But that's not what's important. What's important is the fact that there are 39.8 cents of that dollar that are somewhat manageable and we can do things with, including the prescription part, including profit and other things. But we have no idea, and we have no way of dealing with inpatient hospital cost or outpatient hospital cost or doctor office visits or other things that are related, emergency room. All of those are not counted. Nobody attacks them. Nobody looks at the costs that are out there. We're looking at the 54% of that 39.8 cents that maybe we can do something with. So let's beat up on PBMs. And I appreciate the fact that we're having this, because I think this opens a door for a much more candid look at it. You said it yourself. I agree completely. This is not PCMA saying it. This is Kim saying it. I think we have a healthcare system that is chaotic because we don't communicate with each other. we have a lot of people that really care, and a lot of people that are very smart, and a lot of people that are trying to do the very best, but nobody communicates very well. Maybe someday we could fix that. We wouldn't have some of these challenges. PBMs are the systems. They are the engines. They are the bells and wires and connectivity that takes place to make everything related to the pharmacy benefit touch all other pieces. And I'll give you another example. When I was at CMS, we were writing the rules for Medicare Part D, we had this really bad thing happen. It's called Katrina. And Katrina disrupted everything that took place on the Gulf Coast, but we in Baltimore still had to find a way to write the rules for what would start the next January 1st of 2006, so that no matter where those individuals went, we could get them Medicare Part D benefits. I was also on the Texas Board of Pharmacy, and I served 12 years there. I had 2 different Republican governors appoint me back-to-back terms, which was really strange in Texas at the time. But I was there, and we had to change our rules, like other state boards did, so that we could figure out how to get prescriptions to those people who are now without a home. They don't have their medicine bottles. They don't know where to find it, and many pharmacies were no longer there. But it was the PBMs, through their systems, their connectivity with all of the things that were out there, that could find what those people had. They could tell the new pharmacy wherever it happened to be, and those people got their prescriptions. That is the conduit that PBMs represent. We're trying to find something around cost. It's always trying to something that they're doing that's hidden behind the cloth. That's not really happening. PBMs are the tool.
Thank you, or Ranking Member. I've got other questions for later.
All right, thank you, Mr. Franklin. And next, I want to recognize Mr. Carter from Georgia, but before I do, I want to state the fact that Mr. Carter is not on the Oversight Committee, he's on the Energy and Commerce Committee, and one of the roles that the Oversight Committee will play in the majority is we want to provide oversight and work with all the committees of jurisdiction to provide excellent oversight. We're going to hold forums, we're going to do probes, we're going to have hearings that are substantive, and we're going to work with the committees of jurisdiction on any potential legislation moving forward. So Mr. Carter's on Energy and Commerce. Mr. Carter is also the pharmacist, owns independent pharmacies.
No longer on any pharmacy.
Okay, no pharmacies, but he is a pharmacist and our member from Energy and Commerce. At this time, I yield to Mr. Carter from Georgia.
Well, thank you, Mr. Chairman, and thank you for allowing me to participate here. Mr. Chacha, you just heard what Mr. Caldwell had to say, and I read your papers all the time, and I find them to be somewhat balanced. I mean, you bring out some good points often about what PBMs can do. Do you have any response to what he just said as far as its connectivity especially? I find that very disturbing, but I don't want to preface this. I just want to give you a chance to respond to that.
To the chair, to Congressman Carter, the functionality that PBMs provide in the drug supply chain, I believe, is actually very crucial. If left to their own devices, let's just look at the supply chain very simply. Drug makers would ostensibly like to charge as much as the market would bear. They sell to wholesalers who would love to charge as much as the market would bear. And they sell to pharmacies who would also like to charge probably as much as the market would bear. For those that pay the bill, all right, employers, government programs, et cetera, they need a necessary balancing friction to say, well, maybe not as much as everybody else who I just mentioned would like to charge. And so PBMs were brought in to act as a necessary facilitator of the transaction and as a necessary balancing act to make sure that drug purchases were efficient and also make sure that access was available for beneficiaries on behalf of plan sponsors. What happened over time is that became distorted. Rather than just working to make things more efficient, they actually created, I think, they added more gasoline to the fire of rising prescription drug costs. If you and I were to go into a grocery store and buy a gallon of milk and see that it was $20, we would know we're getting ripped off, right? We don't know that with prescription drugs. And so anytime that somebody makes money off of the list price of medication, all right, there's a big delta between the list price and the real price of that drug. And so anybody who can make money off the delta becomes compromised. And when PBM stopped essentially just acting to facilitate the claims transaction and instead started making money off the drug makers through the rebates, off the pharmacies through the clawbacks and the spread pricing, their incentives became incredibly distorted, and you essentially had the saint become sinner. And unsurprisingly, the entire drug channel now, including PBMs and health insurers, as was said earlier, benefit when list prices become further and further disconnected from reality.
Absolutely. And to your point, I'm old enough to remember when PBMs were nothing more than processors. They were processing claims, and they did serve a good purpose for that. But they have become much more than that. We had a hearing in Energy and Commerce back in May, and we had Dr. Gupta had spoke to us as a witness, and he testified that only 53% of what patients spend on prescription drugs makes it back to the manufacturer. 47% goes to the middleman. Can you justify the value that PBMs bring to the healthcare system in order to get 47% of the cost of a drug?
Mr. Chairman, Congressman, based on the services that we see traditionally provided, the answer would be no, right?
Okay.
You know, what we typically see is that a PBM service, and this is generalizing and somewhat unfair, a PBM, anywhere from $1, $2, if you're really going high, $3 for the administrative functions per claim to fulfill their role. And the Ohio Medicaid audit that showed PBMs taking about $6 per claim, all right, that was about 3 to 6 times the going rate according to their own audits. So the question is not whether or not PBMs deserve to be compensated. The question is, how are they compensated, and do they have the ability to print their own money when facilitating the transaction? That becomes the problem.
Okay. All right. Let me move on. Thank you for that. Mr. Ocon, I want to ask you, DIR fees, we've been talking about that, and they have gone up from $229 million in 2013 to an estimated $9.1 billion in 2019. Unbelievable. As I believe Ms. Jones pointed out, 91,500% increase. Now, understand what a clawback is. As a pharmacy, you get paid, and then months, sometimes years later, the PBM comes back and claws back that payment? How do you operate a business like that, or do you?
You can't, and I'll put this in simple terms. And first of all, I'll give you an update, Congressman. In 2020, it was $11.2 billion. So that's an updated figure. Bottom line is, imagine going to a supermarket, buying 25 items for $4, paying your $100, walking away, and imagine 6 months later the supermarket sends you a $10 bill. For what? You don't really know. You're going to say, I'm never going to that supermarket again. That's it. You're not going to pay it. That's what a DIR fee is. The problem is that a pharmacy, whether it's an independent pharmacy or associated with an oncology practice, cannot say no because the clout of these PBMs. So they can't say no, and not only that, they don't pay the money. The money is taken out of their reimbursement. So this is a game that's rigged just like 3-card Monte is rigged on a street corner. And it's why you see the amount of money that now PBMs make from DIR fees. And I think it's because their rebates have become under attack. So they've gone downstream to independent pharmacies, to practices that have pharmacies, and that's what they've done. It's crime.
And ultimately, who suffers?
Ultimately, the patient.
Thank
It's
you.
the patient.
Thank you, and I'll yield back, Mr. Chairman.
Thank you, Mr. Carter. Now I want to recognize Mr. Gibbs from Ohio.
Thank you, Chairman. You know, sitting here listening to all this, and I think Dr. Feldman said about competition. Well, there's no competition. We got vertical integration, we got consolidation, we got monopoly. It sounds like to me. I'm really a novice in this issue, but I know we've had consolidation and vertical integration in other sectors of our economy that haven't got as bad as this, where you have clawbacks and DIR fees, and it blows me away. Now, Mr. Chakawa, you stated that in the previous question, I think you went that scenario pretty good, and you talked about in Ohio. What has Ohio done, state of Ohio, legislatively to address this, or what's the status going on with this, with the PBMs?
Through the chair, Congressman, appreciate the question. So Ohio, this has been a saga. It's been going on since 2018. The first Columbus Dispatch article that was one of about 200 over the last 3-4 years investigating this. It's been an ongoing issue. So the first thing that happened was after the state found out that the PBMs were pocketing $244 million in just 1 year of the Medicaid program, they were understandably upset. And so they banned the practice of spread pricing. They fired the 2 PBMs, they canceled their contract, and moved to a transparent pass-through model. As I mentioned in my testimony or alluded to, they thought that that would solve the problem. It didn't. What ended up happening is when the state said, okay, PBM, you can't pocket the delta between what's paid and what's billed, the PBMs flowed the money back through, okay? And so what we found was that there were select medications that started being wildly overpaid to pharmacies. Specifically, there were specialty products. So pharmacy owners across the state were rejoicing in that all of a sudden PBMs arbitrarily decided to be altruistic and overpay them for a certain amount of medications that they dispensed. What we learned later was that a majority of those medications were predominantly filled through pharmacies that were owned by the PBMs
Yeah, that's what I was
themselves.
getting at. Yep, so you had the vertical integration going on, you had conflicts too. And so what's any status, where are they now?
So the state is moving to a single transparent PBM relationship, and so they're doing 2 very important things. Rather than acknowledging the fact that vertical integration has complicated the incentives of their managed care plans, they've said, look, we're going to have the direct contract with the PBM, and we'll set the terms to make sure that there's nothing nefarious that might exist between the MCO and the PBM. The second thing they did is they said the PBM is no longer going to be allowed to use pencil and paper to set drug prices within the program. So they hired an external intermediary, a firm called Myers & Stouffer. They actually do work on behalf of CMS. Their sole purpose is to act as an oversight vendor and to make sure that prices are set objectively rather than subjectively by the PBMs. The only other fallout that I'll mention is that they're suing in Ohio. So Attorney General Dave Yost sued one of the PBMs and managed care plans that were involved in the scheme. That PBM never admitted wrongdoing, but they did send an apology note along with $88 million back to the state and have set aside an additional $1 billion to settle fraud, waste, and abuse allegations in other states across the country. So we are still trying to wrangle this thing, and the prescription drug prices that the state is still being exposed to are still very distorted even to this day, which is why they're making this big switch.
I thought in your previous answer to a question from another member, you talked about, in the beginning, PBMs actually provided a legitimate, valuable service, and then they kind of mutated or whatever to this other problem. And it seems to me that's because of consolidation, ownership, vertical integration, no competition, no price discovery. And so that really sounds like a trust issue, monopoly type issue. Am I correct? Is that correct thinking that we need to break this up?
So to Chair Congressman, I have real big concerns with the poor incentives that the current marketplace has yielded to them, right? They are not fiduciaries. They do not have to serve the interests of their plan sponsor, as evidenced in Ohio and a number of states across the country. And so I do think that they're, especially, and I'm not an enemy of vertical integration by any stretch, but I think that it requires a tremendous amount of accountability and oversight, especially when government funds are involved. You have companies now that are insurers, they are PBMs, they now own prescribers and physician practices, they own pharmacies. They have the entire distribution channel and are able to send whoever they want the bill at the end of it. And when you have an over-consolidated marketplace with opaque pricing, the consumer who purchases those services is largely underarmed to make sure that they're buying something in an efficient manner.
Okay, well, but you do agree that we need it, if we don't break them up or create competition, we do have a regulatory function to address it on a regulatory basis somehow.
At the state level, we have shown that regulatory and legislative action is necessary. I would argue that at the congressional level, especially if we're going to take legislative steps to tackle prescription drug costs more broadly, as I mentioned in my testimony, impossible to do so if you don't have the central component of the drug supply chain involved in that dialogue.
Thank you. I yield back.
Commissioner Gibbs, now yield to Mr. Norman from South Carolina.
Thank you, Chairman Coleman. This is the most informative, best meeting we've had all year. We've been on oversight. We've been concentrating on roads that have not had diversity and trees that were racial. So I'm glad we're having this. Ms. Sakaya, in my world, and we're builders, 2 things that keep me honest: competition. What's the cure for this? In short, I mean, what would you have us do as novices? I know Diana and Buddy and others are in the business, but what do we need to do to solve this?
So, to Chair, Congressman, there has to be a significant amount more transparency that exists
And
today.
how do we bring that?
All right, so one mechanism is a full requirement of visibility into rebates, and not just what the PBM defines as rebates. All drug maker price concessions that are flowed back from drug makers to PBMs or their GPOs or their insurers, you name it. All right, we need visibility into how big those dollars are and where they're ultimately landing at the end of the day. Are they going back to the plan sponsor or going back to the patient? Is the patient being exposed to an out-of-pocket cost that's significantly higher than that? The whole reason that we found what we did in Ohio was that we had little glimpses of information available through publicly available data on CMS's website. That data could be far more robust and far more comprehensive and cover even different layers of the supply chain than it does today. The second thing is, I would say, you need to start working to divorce conflicts of interest between those who are price setters and price takers. Anybody that essentially can name their own price in this system will be able to take advantage of it if given enough latitude to do so. You can imagine how foolish we would think that this system would be if we went to Walgreens or Rite Aid or Kroger Pharmacy and said, just send us the bill. You know, we don't care what you say, just go ahead and send it. Of course we'd be getting ripped off because a price taker is setting price. And so anything that you could do to start divorcing that role and creating, essentially restoring PBMs to their true functionality, to me would be a very good policy.
Could you give us a roadmap or what's been successful in, where'd you say, Pennsylvania?
In Ohio and a number of states.
Ohio. Would you give us the roadmap that they did so we can start that in I'm from South Carolina, a particular state? If you would do that and let us begin the journey. I'm for everybody making a profit, including PBMs, but it's got to have a competition element to keep them honest, as it does with me and others. Mr. Caldwell, can you explain what a step edit is?
Yes, sir. I can explain the step edit, and there are other things I'd like to respond to since everybody's been beating up on me, and I haven't had a chance to weigh in here in a few minutes. But a step edit is a process where a patient, a member, a beneficiary has been given a prescription. It goes through the system. It looks to see if you have had the prerequisite drugs that were listed before as developed by the clinical teams of whoever the payer may be that has determined. So that it may be that you're going to be on a blood pressure medication, and it may look to see if you have started with a diuretic before you're out there. If you were naive on drugs, and I'm just picking that one as an example, it may look to see if you've had a diuretic before you take something that is more robust of a therapy, if you've never had anything to help lower your blood pressure medicine. Assuming that you have had something, because in most cases they will have tried that at least once before then, the system will look at it, it'll acknowledge it, it'll check the box, and that was a step. It ran through, nobody saw it happen, it happened behind the scenes on the technology pathway.
Well, and by the way, we're going to have a number of hearings. You'll have a chance to respond to everybody, whatever they say. We're not beating up on you. This is an information.
No, I'm having fun.
This is an information gathering. Now, do manufacturer rebates to PBMs factor into this coverage?
No, sir.
It does not.
It does not.
Do PBMs ever directly link rebates with medical necessity?
Rebates? No, sir.
They don't. Okay. Ted, Mr. Ocon. I've heard from Dr. Kashyap Patel, he's an oncologist in my town, regarding a recent coverage policy that United Healthcare implemented in July that would restrict cancer patients' access to chemotherapy-induced nausea treatments. Essentially, their policy would require chemotherapy patients to, quote, fail, which would experience a violent bouts of vomiting, nausea, before they would approve newer treatments for patients. Can you talk about this? Does it exist? Tell me.
It exists, Mr. Norman, in several different categories. Number one, in antiemetics, or drugs that basically, chemotherapy, as you probably know, can produce a lot of vomiting and emesis, and basically what these antiemetics do is stop that. This step edit, which we call fail first. You have to fail first. In this case, you basically have to have 2 violent attacks of vomiting before you get the drug that could have stopped it in the first place. We see it in the iron market as well, too, especially during COVID, where basically patients had to come in numerous times to get basically an iron therapy that they could have gotten from one administration. And I will tell you, I just spoke with a company that literally one of the largest insurers / PBMs said, if you do not give us a 4.75% administrative fee and a 45% discount, that's almost 50%, that your drug will be declared medically unnecessary. They did not agree to do that, and their drug is now medically unnecessary. Imagine a PBM / insurer making a medical decision based on how much they're going to get paid. This is what happens every day in the world of oncology.
Well, I'm not for litigation. That's where litigation would stop something like that. You got to give them enough downside where they would not do that because of what they would pay out, like the sum that was mentioned, I think, Mr. Sakai. Thank you so much. My time is out.
Thank you, Mr. Norman. We're also very blessed to have participating in this forum an expert on this issue, another pharmacist, Representative Harshberger from Tennessee.
Oh, thank you, Mr. Comer, for allowing me to sit on this committee hearing today. You know, I've been a pharmacist and a compounding pharmacist for over 35 years, and I've been waiting 35 years for a committee hearing just like this. And I'm going to tell you, I took notes on everything that each one of you said, and I have been fighting this for over 30 years, and I understand it. You can't fix a problem unless you understand it. For heaven's sakes. You know, 2 years ago, I read an article by Susan Lang out of XIL Consulting, and you may be familiar with it. If you're not, I'll give it to everybody on the committee. And it talked about, this was 2 years ago, a new analysis of CMS data that payers and pharmacy benefit managers are profiting from obscure pharmacy fees at a rate in excess of 500% per prescription compared to the average PBM administration fee. These direct and indirect remuneration fees, which is like reading a cable bill. Does anybody know how to read a cable bill? That's what it's like. And I didn't even know these existed when I was looking through reconciliation in my own pharmacy, and I'm like, what's this? They were taking back money 6 months later, and I've talked to pharmacy owners who have multiple pharmacies, and they've taken up to $2 million back. How can you even set a budget, a month-to-month budget, much less know how to allocate funds for the next year when you don't know what they're going to take back out of your remittances? And if you don't give it to them, they'll just take it back out of the new remittance coming out every month. And I've talked to you, Ted, about this, and it's almost like a step approach or a prior approval process. You have to have 2 exorbitant bouts of nausea and vomiting before you can get an approved drug. And Dr. Feldman, your rheumatoid arthritis patients, for God's sakes.
With all due respect, Mr. Caldwell, I can tell you that the rebates do play into step therapy. Oftentimes, I have to choose a drug that is as more expensive before I can get to a less expensive drug. I mean, the example of the $10,000 metastatic prostate cancer drug is available on the formulary. Through appeal, a much higher tier, you have to step through the $10,000 one before you can get to the $350. Don't tell me that rebates and kickbacks, don't have anything to do with it. And one other thing I'd like to dispute, he says the employers are asking for this. I started giving PBM 101 lectures to Rotary clubs around Louisiana. My husband's very active in that, and they keep asking me. I have employers coming up to me afterwards saying, now I understand. One self-employed, self-insured, she said, I have atrial fibrillation. I've always paid this one price for it. I signed the same contract every single year. Yeah. This year, that same drug now costs $500. I've had to go into the hospital, get cardioverted, and now I'm on 2 other drugs. And that is because another manufacturer came in with a bigger price concession and kicked her drug to a higher tier.
You want to know what you know what that's called? That's called pay to play.
Absolutely.
And there's no other way to put it, and I've said this over and over. And, you know, just within a year span from June to July, 2,200 independent pharmacies went out of business because of these DIR fees. I'm just getting started, okay? We're talking about vertical integration, and when you have a pharmacy to buy a pharmacy benefit manager, and they're like, oh, we're going to keep that separate, there's no problem. I knew that was a lie. I wrote a letter to the FTC when I came on board, and this is, you know, I'm a freshman like Scott and like Andrew, and I'm like, who audits the pharmacy benefit managers? You know what? I got no response. There's things, these rebates have doubled. You know, I'm looking at some other things. Ms. Jones talked about, with the specialty drugs, you're talking about these networks. It's a take it or leave it mentality. You either take what we're going to reimburse you or you leave it. And there's closed networks too that you you don't even have an option to get into. And that's not to even talk about the other problems we have. I can dispense a drug and lose money every single time. Why would I do that? Why would any of these pharmacies do it? That's why you're losing. You know, you talked about the 91,500% increase. Our customer care, our patient care didn't decrease, did it? It absolutely did not. We still took care of those patients. It is a travesty, and I know my time's running out. Anybody wants, can I keep going? Yep. Oh.
You're doing great.
Okay, well.
And we'll let, Mr. Caldwell, we'll let you respond. After everyone goes through a round of questions, we're going to allow people to respond if you
yeah.
prefer.
Well, thank you. Thank you, Leader. You're precious. And welcome me back anytime. I'll come back. Why didn't I ask for oversight? You know, there's a loophole in the program that allows health plans and PBMs to pocket, and I'm reading from this article, an excessive amount of pharmacy DIR fees rather than offset prescription costs for seniors. That goes back to the insulin example. Many seniors struggle to afford those medications, but they don't experience any benefit from these discounts to reduce the cost of prescriptions at the pharmacy counter. I talked to a generic company. They have an insulin that's $140, but you know which one's on the formulary? The $900 one. That's a travesty, and you wonder why the cost of drugs are up and everybody's screaming at us. PBMs are part of the problem, and now I was on a Zoom call last night with Senator Marshall. They're going to do the same things with the labs, and they're going to cut the pricing and the reimbursement on those. And it's the same thing. These things didn't exist. I used to have to do it with the credit card machine to bill PBMs. But what's happening to you, Dr. Feldman? What's happening to the chemotherapy patients? Ralph is right. There needs to be some litigation with this. It's a pay-to-play, and I talked to a pharmacist in New Mexico. And you know what he said? I got my new Aetna contract, and it says this is your reimbursement fee, but if they do away with these DIR fees, this is your reimbursement. They already know we're after them, and they're going to skirt everything again. Now, I could go on, but you know what? I know Andrew's waiting.
Right. Well, thank you, and I think we'll have time for another round of questioning for the members who want to participate, but now I'd like to yield to Mr. Clyde from Georgia.
Well, thank you very much, Ranking Member Comer. You know, as a small businessman myself, you know, I understand what it takes to run a small business, and I cannot imagine, you know, I mean, I sell guns for a living. I don't do drugs, okay? So, but I cannot imagine being held hostage by what I understand to be a DIR fee. But I better understand why small businesses, why small pharmacies are now going out of business. And how this can possibly be a good model, business model for a small business is just stunning to me. It sounds like extortion, really. And on that note, I think I want to yield back to our freshman representative Harshberger to keep it up, because I like what I hear.
Well, you are so kind, Andrew. You know, I want to go to you, Mr. Cha-Cha, because it's going to be the states that protect us from all this right now. You know, the PSAO contracts that we have to sign, we don't see those contracts. We do not. And when we argue or we have a complaint about reimbursement, we have to call that PSAO, who holds the contract and negotiated it for us, in order to find out what that reimbursement rate is, which is a travesty. Some of the bigger ones, we have to directly contract with them, like Express Scripts or CVS Caremark. Ralph Norman talked to you about what do the states need to do. It's a right to be able to, our state just passed a law that said you cannot reimburse a pharmacy less than what they paid for the drug. How pathetic is that you have to put that into a contract for the state so these pharmacies won't go out of business? There's so many things. Most favored nations clause, if you give it to one, you got to give it to the other, but we don't have the ability in a lot of ways to see what those negotiated prices are. But transparency, there are PBMs that are transparent out there. And I've talked to Vintegra, and I've talked to several of these PBMs that are run by pharmacists, that you know what you're going to get, you know what's the formulary, and, from your experience, sir, who sets the formularies with these health plan sponsors?
Through the chair, Congresswoman, at the end of the day, formulary design, I think a PBM would argue is a joint venture, right? It is a conversation between a health plan, a PBM, and a plan sponsor. Yeah. But because prescription drug pricing and the value of certain prescription drugs is essentially inaccessible to lay people, a lot of those decisions are driven by what the PBM recommends. And so a lot of times what we see is that a lot of those recommendations, to Dr. Feldman's point, are very much decided upon what is of best financial interest to the PBM itself. And sometimes that can be the lowest net cost medication, but a lot of times lowest net cost means highest list price, biggest discount. And the discount, whether you define it as a rebate or define it as 15 other different types of fees, is essentially a bad incentive for that PBM because they get to retain at least a portion of that concession.
Yeah. And, how many times, Dr. Feldman, or any of you guys, the complaints from the healthcare providers to me where we have to go through this step approach to get down to what they have to fail on so many drugs.
I spoke to the National Medical Director for Express Scripts because there was a problem with steps, and one company was paying patients to change to a drug that wasn't going to help them. And there's something wrong with my microphone.
You have two on at the same time.
Maybe turn yours off.
It's off.
Yeah, use his.
Yeah. And the National Medical Director from Express Scripts admitted to me, yes, it goes through P&T, Pharmacy and Therapeutics. He says, but at that point, we have no say-so over it. It goes to contracting, meaning rebating, reclassifying as fees, throwing money to rebate aggregators offshore, and they decide, not based on safety, not based on efficacy, but on the largest price concession. And, this came from the National Medical Director for Express Scripts. He says, I'm so sorry, but we can't do anything about it. It's the money that decides the formulary.
Yeah. I want to know who sets AWPs for these drugs, average wholesale price. They don't even use that anymore. It could be another modality now. And, it's just, we have to get a handle on this, and they wonder why the drug pricing is high. Well, we've got answers, and we can be transparent in everything we do, and we can make it affordable to that patient. And, as pharmacists, we had a gag order on us until President Trump took that away. We could not tell a patient that they could go pay cash for something that was less expensive because we had to run it through their Medicare program, which is pathetic. It didn't stop me, but don't tell anybody. But, and my patient is my primary concern. And that's who's suffering, as they said before. That's who's suffering with every bit of this. And with that, I'll yield back now.
Well, thank you very much again. Just sitting here, it's amazing that the Democrats have had a couple of drug pricing hearings and haven't ever touched upon the PBM issue. Now I'd like to yield to Mr. Grofman from Wisconsin.
Thank you. I'm going to start off with two questions for Mr. Cha-Cha. So, as you know, the cost of insulin keeps going up despite competition in the marketplace. It's clear that this is due to the perverse incentive structure that gives manufacturers no choice but to increase list prices in order to provide a higher rebate to the PBMs for top formulary placement. For this reason, I introduced the Insulin Cost Reduction Act, which would require PBMs to pass rebates directly to consumers in the Part D insulin space. Given your research in the field, can you touch on how the system I describe isn't working?
Through the chair, Congressman, I can characterize the current system as nothing short of fundamentally broken. There was an article written by Bob Herman at Axios in July that looked at the price of Lantus. Lantus's list price is around $284 per vial. When you factor in all the discounts and concessions that Sanofi, the drug maker who makes Lantus, actually gives through the supply chain, passes back to PBMs, rebate aggregators, insurers, government programs, et cetera, the net price, what Sanofi takes in, is less than $35. The question then is, what copays are patients charged by PBMs in their health plans within the Medicare Part D program? And the reality is that for those that are in essentially a deductible, they're being exposed to the full list price of that medication, even though their PBM and health plan are cashing checks on the back end on those rebates that are given up by Sanofi. That is ridiculous if a patient is ever exposed to list price, but their health plan, the price that they pay, is around $35. It's ridiculous.
It is. I'll kind of follow up on that. Another provision of the bill is to make cost sharing based on the net price rather than the list price. Can you touch on the research you've seen regarding the rising list prices of insulin despite the net price staying the same or even going down?
Chair, to the Congressman, what we see is a growing disconnect between list price and net price. The net prices of most insulin products are actually going down over time. Some of the authorized generic versions of insulin are not being covered because PBMs continue to prefer the overinflated list prices of the innovator brand products that have the highest disconnect between the list price and the real price.
Thank you. It kind of appears they don't have the best interest of the patient in their mind. I'll ask Dr. Trish one thing. Do I have a second yet? You've researched the negative effects that patients who face high insulin costs bear, particularly in the Part D space. Can you give us a little bit of your findings?
Yeah, absolutely. So my colleagues recently found, just exactly as we were describing, that there's this growth in list prices despite declines in net prices, and an increasing share of insulin costs are going not to the manufacturers but to the rest, or what we like to call the parasitic loss to the system. What we have found is that beneficiaries, particularly in Part D, as they move through benefit phases, they experience increases in out-of-pocket spending or cost sharing at the pharmacy counter because they don't share in the benefit of these rebates when they fill those prescriptions. And that, in turn, we've shown that leads to reduced adherence and really true issues for patients when they're exposed to this higher cost sharing that really makes no sense while they're generating rebates for the rest of the program.
Okay. Is my time up, or I give one more? Okay, Dr. Greider, wherever you are, when you see patients who are prescribed insulin, how often do you see the price they pay at the pharmacy counter increase over time?
So it depends on what phase they are in their initial, if they're in their deductible phase or their maintenance phase, or if they're in a donut hole. So January 1, we're in open enrollment now. If January 1 pops around, those copays will probably be, if they're not getting any help from Medicaid services for those copay assistance or reduced premiums, they're going to pay around $40. Now, if they get a 90-day supply, depending on the plan, of course, the cost share is going to go up and it's going to reach their donut hole a lot quicker. So if they get 90-day supply, they're going to hit that donut hole. They're going to be facing upwards of 80% or more of that copay. I've seen anywhere from $250 to $300 copays. Some of the plans have limited those copays to $35, but not all plans are doing that currently this year or coming next year. So it really depends on A, what plan they have, B, where they are at in their phases of Medicare D, whether it be deductible or the donut hole. And so it varies greatly.
I'd like to thank the ranking member for having this hearing. It'd be nice. Hopefully some Democrats are in their offices listening. Thanks.
Well, thank you. And we've had the panel go through one round of questioning We budgeted 2 hours for this committee. There's so much more to talk about, and we're going to proceed. If other members have other questions, we're going to do that, and then we'll let everyone, I guess, have a closing thought, or if Mr. Caldwell, we'll give you an opportunity to respond to some of this. And again, we appreciate you being here. A good committee hearing has both sides, and unlike the committee hearings that the majority parties conducted this Congress, we're going to issue a report, and we're going to try to actually do something about the problem, and it takes all the stakeholders working together. But Dr. Trish, in your research, what do you think a solution would be that Congress could do? I mean, we're pro-business up here. We unlike some of the more left-wing members of Congress, we appreciate the private sector. We appreciate the pharmaceutical companies for investing in research and development and for creating innovation. And to do that, you have to make a profit. We understand that. We don't discourage anyone from making a profit, but what can be done about this issue that reduces the price for consumers to purchase pharmaceuticals without infringing upon private business or without harming the system that's in place? What can we do in Congress?
Absolutely. So I think, we've heard some discussion around the need for greater transparency, better insight into understanding, so we can analyze and really, provide some true metrics around what's going on. But I think in terms of options to really, reduce or mitigate the concerns for patients, we really do need to move to push these rebates with patients, or to share rebates with patients at the point of sale. It makes no sense that their cost sharing does not reflect the true net cost of these drugs, and that they're the ones suffering from paying this higher out-of-pocket spending when their cost sharing is based on these inflated list prices. So I think one key issue is ensuring that the patients benefit directly from these cost reductions that are negotiated. I think there's a wide range of other issues that would take the crux of increasing competition in this market. So we've heard about options to better align incentives, things like impose fiduciary requirements on PBMs, so they're working not just for their shareholders, but also for the clients that they're serving. But I think there's also an opportunity, as part of the kind of broader drug pricing discussions, to recognize that we can improve the nature of competition in the Part D market. There are some provisions around redesigning the benefit structure that would give plans more skin in the game. That would in turn incentivize them to more strongly put pressure on PBMs, whether they are the PBM or are contracting with a PBM, to truly improve competition. And that's a very market-based approach that could solve some of these issues by kind of restoring the Part D program to the competitive nature that it was originally intended to be.
Okay. Ms. Jones, what if you had advice for us? I mean, we sincerely want to help the situation. I believe with all my heart, not just based on this hearing today, but based on countless conversations with healthcare stakeholders throughout Kentucky, that if there's a transparency problem, I agree with Mr. Caldwell, there's a communications problem. What are some things that we can do in Congress to help the situation?
I think the proposed bill, as I stated, is a really good place to start. And I echo what's been said. Transparency is the most important tool here.
Mike, I'm sorry.
Sure. Is that better? Yeah, transparency is the most important. At the end of the day, what we're talking about is patients aren't able to afford their drugs. Independent pharmacies aren't able to service those patients in the networks because PBMs are taking so much money that they say, well, if you don't like it, just get out of the network. And that's what they want in the first place anyway. So what we have to do is like everyone has said, know where is that money going? Let's see what they're actually getting in a rebate. Let's see what they're actually paying. And then let's have regulations in place that don't allow them to sidestep the laws that are in place now. There are any willing provider laws in place, but PBMs are able to sidestep those by just offering poor reimbursement. And CMS will not get involved in reimbursement negotiation at all. And so if a PBM wants to reimburse a pharmacy underwater, there's no law saying that they can't do that. I mean, the law says that they have to provide reasonable and relevant reimbursement rates, but regulatory agencies have not been willing to get involved and say what is actually a reasonable price. And this is a money issue at the end of the day. This is a reimbursement. This is a cost issue. So, you know, PBMs can frame it as a rebate issue, or we can talk about it's a transparency issue, but at the end of the day, this is all about money. And as long as the regulatory agencies are not willing to get involved and say you can't reimburse a pharmacy underwater, we're still gonna have the problem.
With respect to a complaint that every pharmacist on this panel and the pharmacists testifying today and pharmacists all across America, the question of transparency with the Dir fees and the frustration that they get for issuing a prescription and then 6 months later getting a bill for that. Is there a better way to do that? Is there a way for the pharmacy to kind of know what fees they're going to have to pay? Is there a better way to do this?
Well, Congressman, if I can, let me explain what that is. There is a contract that works on the adherence, and until time has passed, you don't know if the consumer, the patient, the member, the beneficiary was adherent. And so it runs a period of time. And one particular plan that I was part of, we put this in place. The pharmacists themselves submitted their own data. They looked at their data on a regular basis. They knew when it was going to be, but it would be typically no more often than every quarter, but it could be 6 months before there was a true-up to say, yes, there was move-in adherence or there was not. They knew exactly how much money was being held or withheld or going to be on hold up until that time, but until they get to the results, it's not like you can guess and say that Kim was going to be adherent. You had to wait and see if I, as a patient, was adherent on that drug, and that pharmacy was helping me go through the process. I understand what you're saying, but we need to understand this is part of their contract spelling out these are the dates as we go through.
And again, I don't doubt that it's a part of the contract. I just think that
But it is
there
one
has
of those,
to be a better
until
way.
it happens, you can't make a determination until the time has passed to see if the member was adherent on those. And I'm using the three that I gave you examples of that I'm familiar with these particular contracts that's out there. So there is a window of time, clearly get it, but it's not like you can guess that they're going to be adherent. You have to wait and see if they were. And then payment or lack of payment comes there. Clawback is a word that is being used, but that's not exactly correct either. There was a problem with clawback several years ago. And to my knowledge, all PBMs have stood on the line and said, we won't do that anymore. That was a mistake. But these are not clawback. These are contractual arrangements on payments for service or non-payment for service that have nothing to do with the drug itself. It has to do with the service of driving adherence. And there are reasons why adherence is important, but is it DIR? Yes, and it's DIR because the law says everything, all monies, expected or not expected, known or not known, that come in through the system is considered direct and indirect remuneration. And CMS expects that to be counted in the bid in June before a plan year, and then they true it up. There is an auditing by CMS, and OIG oversees CMS to make sure that they have done it, to make sure that the right amount of DIR was accounted for. If not, if there's too much that was gained, the plan has to give it back. Or if there's wasn't enough, there may be something from CMS. Those happen on a regular basis.
It sounds like a clawback, and it just seems overly complicated, and that's something that we need to work on. I'll yield to Buddy Carter.
Ms. Jones, you talked earlier about, well, first, before I get to that, let me ask you something. Ms. Jones, Mr. Okan, he just said the PBMs have got together and said that they're not going to do clawbacks. I thought you said, Mr. Okan, that it went from 9.1 to 11.2. If they've stopped, then holy cow, we're in trouble.
I think, Mr. Carter, there's a definitional problem, and I think that is that PBMs, it's always a flim-flam game. As I said, it's like three-card Monte where, oh yeah, we're not going to claw back drugs, but we're going to extract these DIR fees. And let me tell you that, yes, I understand they measure adherence, so you have to measure that after the fact, as Mr. Caldwell said. But can you imagine being an oncologist and being measured in part on adherence to something that has nothing to do with cancer care? It has to do with diabetes, it has to do with cardiovascular disease, and even the portion that you're measuring, that you're saying, well, there is a portion we're measuring in oncology. As you know, as a pharmacist, Mr. Carter, there are situations where you do not, where a patient, a cancer patient, needs to be stopped on their medication because the tumor isn't reacting to the drug or it's changed, and therefore there is no adherence. But that's what they're measuring from afar. So this DIR report from CVS, this report, as I said, I defied anybody to understand what this is about. This is just an excuse to, in essence, claw back monies, because even in these so-called quality programs, you don't get, if you do a good job, you don't get a reward, you always get dinged.
Okay, I want to go, Ms. Jones, I want to ask you, because you mentioned in your opening testimony about steering, and that's something that I've experienced in my retail pharmacies back when I owned them, and I want to share a story with you. And I'm not embellishing this, and I'm not making it up. This actually happened. I was working one day. My wife had prescription coverage from a different company at that time. I filled a prescription for her at my pharmacy that day. Got home later on that night. Around 8:30 at night, I get a phone call from the insurance company. I answer it. They said, Mr. Carter, we see where Ms. Carter got a prescription filled earlier today, and we just want to let you know that if you get it filled at our pharmacy, your copay will be lower. I said, you're kidding me. I never knew that. And he said, yeah. I said, well, where did she get it filled at? And all of a sudden it was click, and that was it. Now, but tell me about steering, Ms. Jones. You see that in specialty pharmacy. And Ted, I know, excuse me, Mr. Oken, I know that you've expressed concern about steering before as well. Go ahead, Ms. Jones.
Every single PBM engages in patient steering every single day for every single patient, period. You know, I think almost everyone here in their testimony said the same thing, and that's that the top 3 PBMs control more than 80% of every single drug transaction in America. So that means that the insurance company for every single PBM can see where every single prescription is filled, and they have that patient's phone number, and they have their wife's name, and they call or they send them a letter, and they say, if you don't get your drug filled at the PBM-owned pharmacy, you're going to lose coverage. You know, and we have an entire team of people. I'm one of them. I talk to patients and tell them that's not true. You don't have to transfer your prescription to their pharmacy, and you know, there's a reason patients don't want to. You know, as an independent pharmacy, every single patient we have has the option to use the PBM-owned pharmacy, right? So every single patient we have has chosen to use our pharmacy over the PBM-owned pharmacy, and there's a reason for that. That's because we have to compete so our service is better. But we tell them you don't have to transfer, but who would you believe if you were a patient and your insurance company was telling you you're going to lose coverage? Some of these drugs are $50,000 a month. And they're scared and they're sick, and I don't blame them for transferring, but it's sad because they have right under the law to choose their pharmacy, and for good reason, and there should be competition.
Dr. Feldman, have you ever experienced this in your practice where you've had patients who said, all of a sudden, you got to get it from this pharmacy?
In doing prior authorizations and finding it, yes. Normally after, I'd say maybe one fill, I have patients that come back and say, they're not going to count my copay towards the deductible unless I use their mail order. They're not going to, you know, let me get a lower copay unless I use their specialty pharmacy. It is, they're being steered right and left. And we have one person in our office that does all of the prior authorizations, and he is constantly busy trying to change patients around because the PBM comes in and entices the patients.
Have you had an experience where you had a patient on a drug and they were doing fine on it, and all of a sudden it fell off as a tier 1 or whatever, and then
Absolutely.
you had to go to another one?
Absolutely. And they lose, the containment of their disease process. I've had patients that then had to go and get a knee replacement because the drug that was treating them so well and keeping their joints intact, years later never did make it back onto the formulary or never did make it to a spot where the patient could actually afford it. And the rheumatoid arthritis got worse and worse and worse. You know, everyone here is pretty much either talking about dispensing or talking about pharmacies, but I talk about the patients. And I really want to emphasize that last thing that I talked about, a test, and how the PBMs have put their nose into that. We keep talking about personalized medicine, and there is a test that will show that 40% of patients will not respond to a tumor necrosis factor inhibitor. Think of all of them, the Enbrels, the Humiras, the Janssen drugs, the Remicades, all of those that are made by very big pharmaceutical manufacturers. 40% of people won't respond to that. My patients all have to step through at least one of those first. So now, here's a test that 40% of people will not respond to the most profitable drugs for the PBMs, and there is a PBM out there trying to make it so the employer cannot offer that test to their employees. That should be criminal. This proves that profits are above patients. And I'm all about profits, but I'm not about profiteering, and that's what we're seeing here.
Thank you so much.
Mr. Carter, Ms. Gibbs from Ohio.
Yeah, thank you. Mr. Caldwell, can you respond? We've heard witnesses testify about in the formulary process, there might be a drug that costs X amount of dollars and then another drug that's a lot cheaper, but they can't have access to that through the PBM. And I think a little bit what Dr. Feldman just discussing too, just respond to that, I guess, to help me understand why that is. Why just because it doesn't seem to make any sense. We want the best for the patients, and we don't want to bankrupt patients at the same time when they're sick.
Well, there are a variety of things there. Thank you for asking the question, Mr. Gibbs. It's hard for me to respond to all 70 PBMs that are out there. So, I mean, there is a lot of competition. There are 70 that are out there. And in commercial, they turn over roughly every 3.5 years. They don't do it that in Part D, but in commercial, they do. But there are Pharmacy and Therapeutics Committee that are made up mostly of physicians in various specialties, and these are not employees of the PBMs or the health plans. They make up a significant part of it. There are nurses, there are researchers, others, and then you will have a few key people that are relationship to whoever the client is as they're trying to drive it. And frankly, in most cases, there's as they review all of the drugs, and they do them typically by category and class, unless it's a brand new drug coming to market, the experts will decide this is a you gotta cover it drug, or this is a don't you ever cover this drug. Everything else is somewhat in the middle. You need to have a representative example of these drugs. And that's one of the discussion that takes place through the PBMs. If it's in the category of you need to have representative samples of those, then it's a matter of how do we try to get to the best place so that the lowest net cost gets to the premium for all members, and we get to the lowest out-of-pocket cost. And speaking of out-of-pocket costs, we're always talking about all these really high prices that they hit. Well, I don't know of any plan anywhere that charges a beneficiary a net price of the net manufacturer's price that's out there. There are deductible phases that by law say you have to collect the deductible, and once you've got that, then your other benefit kicks in. But every PBM that I'm aware of has a lesser of mindset. The lesser of contract will say it's a lesser of the copays or cost shares that we have developed. It's or whatever the PBM's usual and customary price is, or the adjudication model that we put in place. Whichever one of those three is the lesser, that's what they charge.
I've tried through this a little bit. You said that you have a panel of experts that decide what drugs will be in the formulary, okay?
Well, no, they will tell you which ones you must carry these particular drugs.
Okay. But,
and some you can't because they're not safe for the population they're referring to.
okay, but is there a process or a mechanism where the patient's local physician can apply, let's say, well.
In all cases, even if something is not on the formulary, the physician has an opportunity to go through a prior authorization, and each of those varies by a different organization. And I'm not going to play like all of them are going to be uniformly the same. I will tell you that I have been in numerous meetings with various PBMs over the last several years of trying to figure out how they can get to an electronic prior authorization, so you get to yes or no faster. And if it's a no, then it's an appeal process so that you would get to the appeal process faster, but we're not there yet.
Well, all I would just say from a political standpoint if you got a patient that has required, the only drug it has access to is one that costs thousands of dollars, and there's opportunity for a drug that work that's a lot cheaper, from politically, that doesn't, that's, I don't know, we're making that argument.
So I'll go back to but it's a lesser of mindset. It's either the copay or cost share that comes out of their pocket, or it's what the usual and customary price is of the pharmacy where it was dispensed, or it is based on the calculation formulary. Once you're not in the deductible phase, the deductible phase is typically set, especially in Part D, you have to collect that. And then when you get to the coverage gap, which is what we used to call the donut hole, now there have been enough laws changed over the last several years that have gotten it down so that 25% is all that people like me, I'm a beneficiary, that I would pay in the coverage gap if I was there before we would blow through, and then I'd get to the
I'm just
catastrophic.
about out of time, but Dr. Feldman's about ready to come out of her seat, I think.
It's going to be very difficult to explain why one of the big three PBMs will cover a $10,000 a month metastatic prostate cancer drug, and yet put on Tier 6 a $350 generic of that same drug. It's going to be very difficult to explain that away as lowest net cost.
Yeah, and politically, that is not a good position to be in, just a word of advice from me. I think I yield back. Thank you for being.
Thank you, Mr. Gibbs. Now yield to Mr. LaTurner from Kansas.
Thank you, Ranking Member Comer. I know you're familiar with the 340B drug discount program, which was designed to help safety net providers offer low-cost pharmaceuticals to their low-income and uninsured patients, and to generate savings to support other critical services for these patients. In my home state of Kansas, where 340B hospitals represent just 19% of total hospitals, they provide 61% of all Medicaid hospital care in the state. Some safety net providers, such as the federally qualified health centers, are reporting that PBMs are undermining the intent of the 340B program by effectively pickpocketing the 340B savings that were intended to support these providers and using them to boost their own profits instead. For example, a PBM may reimburse significantly less for a drug if it was purchased under 340B than it would for the same drug dispensed to the same patient under the same plan if it were purchased elsewhere. Small safety net providers like FQHCs lack the market power to push back on these pickpocketing contracts, and thus are forced to hand over the 340B savings intended to support their operations to the PBMs. For example, an FQHC in my home state has been compelled to sign contracts with 4 major PBMs who account for 85% of the prescription claims processing nationally, and who engage in these practices. While some in the industry have pushed back on regulation at the state level on PBMs, there have been numerous lawsuits and settlements on these very practices. And just last year, the Supreme Court upheld an Arkansas law that required PBMs to reimburse pharmacies at a price equal to or higher than their wholesale cost. I'm concerned that these practices by PBMs are driving up costs, not just for 340B providers, but for many other local pharmacies. And I would like to thank Ranking Member Comer for having this conversation today about what we can do to conduct oversight of the industry. Dr. Trish, do you believe that PBMs currently have a competitive advantage in the industry? What do you need to do, what do we need to do to level the playing field between PBMs and other providers?
Yeah, absolutely. Thank you. So, I think we've heard a lot about rebates and all of those issues, and those tend to be focused on branded drugs. I think to bring it back to the generics, just to kind of highlight another salient example with the issues with PBMs. I started down this path of research after talking to a generic drug manufacturer who decided that they would go and look at the amount that their health plan via their PBM was charging their employees when they bought the same generic drugs that they were selling into the market that they had created or manufactured. And they found that they were being charged about 6 times higher than the price that they were selling that drug into the supply chain for a common generic drug, right? This makes no sense. And I think the only way to explain that away is to recognize that there is a tremendous amount of opacity in this pharmaceutical supply chain and the distribution system. And that's really not benefiting patients. And as we think about the kind of broader goal here of delivering on value and ensuring that we have dollars to use wisely to pay for innovative new medicines to treat patients where they exist, it's important that we, make sure that we're not losing our dollars on this kind of supply chain that's not providing value to the system.
I appreciate that. I believe it's vital that we have more information about the operation of PBMs so that we know how best to address the problems instead of operating in today's opaque reality. Would you support, Dr. Trish, and others can comment as well, HHS contracting with a third-party entity to collect and review data from state Medicaid agencies and covered entities to prevent Medicaid duplicate discounts?
Yes, I think that's a very key issue and something that I would very much support. I've been studying this market for over a decade, and I still can't figure out what are the price of some of these drugs or where all of these dollars are going. And I'm sitting here today as an economist and as a professor, and I think that the more transparency and the more insight that we can bring here, that comes from starting with a place of good data to study and analyze, and to be able to provide policy recommendations that are grounded in evidence that comes from needing data to do that type of research.
I'll open it up. Would anyone else like to comment? Please go ahead.
Through the chair, our organizations live on drug pricing data. It's everything. And when our consulting work, when we do work on behalf of employers or state Medicaid agencies, state attorney general, or state auditors, really all of the accountability is predicated on the utility and value and integrity of the data that they're operating with. I have worked with state auditors who are trying to figure out where the money is going in the drug supply chain, who are told that under state Medicaid programs or state public employee retirement funds, where the state is shelling out some of the biggest checks for pharmaceuticals, that they have no right to actually have access to the data or the contracts that govern what the state's cost exposure is. That is fundamentally broken. And so anytime that you can get, I'm unfamiliar with the exact policy that you're looking into, but as a fundamental, a lot more rights to data and a lot more granular data are necessary to hold not just PBMs, but the whole drug supply chain accountable.
I agree completely. And just imagine if you two don't understand all of the details, imagine the knuckleheads in Congress. You know what I mean? We need all the data that we can to try to navigate this. I appreciate all of you being here and appreciate your answers. I yield back, Mr. Chairman.
Very good. Mr. Dorman from South Carolina.
Mr. Caldwell, you want to respond to Dr. Feldman about the drug pricing, putting them on a tier 6? Can you respond to that?
Well, I don't know that I can respond to that particular one. I'm not even sure really of the particular drugs that were being mentioned, so that would be hard to say specifically. But I will tell you that there are circumstances where there are rebates that come in. There are market share that is created by prescriptions from various providers and physicians around the country, that the market share times the rebates help buy down premiums, help buy down the cost shares that would be paid by the beneficiaries at the point of service. Those are things that are hard to change, especially if it's in the first year of something else that's being on the market. And I don't know that this is the example that was given here.
Let me ask Dr. Feldman, can you repeat the drug you mentioned that was a 10,000?
I don't know if I'm allowed to say brand names. I will tell you where this information came from. It was an employer representative because it was a self-funded employer. And she went to the PBM and recorded the conversation. And basically, the drug Zytiga was covered tier 2 after the patient had tried something else for their prostate cancer. And the employer was going to have to, fork up quite a bit of money for this drug. And the generic had been out for 3 or 4 years, and said, well, is there any way that my employee, the patient, can get the $350 or $400 drug instead of the $10,000 drug? And that's when they said, yes, the physician can appeal, but the patient's cost share will be more for the generic drug. Maybe they would charge them the full price, $350, whereas if they got the $10,000 drug, they could perhaps get a copay card and it would be zero. And if I'm a prostate cancer patient, I think I'd rather pay zero than $350. And that was and then he went on to list many other medications where the brand name is preferred over the generic.
Mr. Call, you want to respond to that?
Well, it's no different than what I was trying to respond. There are certain, I can't tell you why decisions were made by any particular payer or organization through their PBM or others. It would be beyond me to try to put in an explanation something that I know no details on. I hear what you're saying, and I think it's well worth looking into, but I can't honestly give an answer for there.
Is any of y'all that want to ask Mr. Caldwell any question that, I read your body language on Ms. Jones and Ted Ocon that was on certain things. Anything y'all want to ask him that maybe we have not asked?
I'd like to ask him what I hear all the time, and I just read this morning, Mr. Caldwell, from a urology practice and that we represent, and that the patient was diagnosed with metastatic prostate cancer. They had to go through a approval process to basically get the drug, which is a clear choice. They did. The pharmacy at the practice was not allowed to dispense the drug, and it proceeded to go through a kabuki theater of, it's all the way I can describe it, of 3 different specialty pharmacies that literally were supposed to, the PBM said, you have to go here, no, you have to go here, no, you have to go here, and all along the way, literally they had to get another prior authorization. 3 weeks later, just read this email this morning, sent to me last night, 3 weeks later, the patient got their drug. Imagine you have metastatic prostate cancer. It's in your bones, it's in your lymph nodes, and guess what? The dosing was wrong. The patient's supposed to take 4 pills 1 time a day at the same time every day, and their instructions back were literally from the mail order pharmacy attached to the PBM. You take 1 pill 4 times a day. So this is the kind of thing that happens, I live with all the time, and I submitted for the record 5 volumes of what we call PBM horror stories. These are not one-off, Mr. Caldwell. These are cancer patients, Americans, who every day are trying to get their drugs, and they get more hurdles put in their place by PBMs.
Well, I'm not sure that I heard a question in there, but I did hear a legitimate patient situation. I did hear a legitimate provider situation. However, I will also tell you that there are millions of Americans every single day who get hundreds of millions of prescriptions every single day, and they work just fine. They work well. And because of PBMs and because of the channels where they have arranged systems so that people get them for much less than they would if they went into a pharmacy. Even back in the day when I had a pharmacy, they would go into the pharmacy and pay the price that was out there because, as it was said earlier, the manufacturer wants more money. They don't want to give rebates or discounts. The wholesaler wants more money. They don't want discounts. The pharmacy wants more money. They don't want to give a discount. It's a system where the price of drugs, which are created by the manufacturer, and they're the only part of the healthcare system that can raise the price anytime they want during a planned year, those are the prices. PBMs have found ways to try to keep that in check and try to make it so that the payers can have as low a monthly premium as possible for the people, because if they can't pay their monthly premium, they have no insurance, they won't get their drugs filled. And so it is a process. I clearly understand that there will be things that go wrong. It happens. You know, I wish I could say it didn't. It does, and they ought to be fixed. But that has nothing to do with the fact that PBMs actually do help the system.
I'll ask you a question, if I may, Mr. Norman. Why do PBMs disallow patients at community cancer practices, hospitals, wherever, basically get their drugs, their oral drugs at the point of care? Why does it have to be delivered through the mail? and why, as Ms. Jones has said, and we see it all the time, that PBMs constantly troll for patients so that they can steer their patients where they get their drugs. Why does that have to happen?
Well, those are two different issues. I will tell you, we get calls at my house too from someone wanting me to get my prescription somewhere else. I go to a brick and mortar store because I like going in. I would sign the license for the pharmacists that are in there, and I'd like to visit with them. So, yeah, that happens on a regular basis. I can't give you answers why it's out there. It's part of doing business, I suppose. Why is it that the medicine has to come from a particular pharmacy somewhere else? There could be a variety of reasons, especially if it's a product that falls under what would be the specialty range, because there are different means of dispensing those. In fact, some manufacturers will limit the number of pharmacies. They will do a controlled distribution model to just a handful of specialty pharmacies. There are others where if you have a network and certain specialty pharmacies are in your network, it needs to be through one of the network pharmacies if you're going to have the copay or cost share that's out there. And if your physician group or hospital is not part of that network, that's not how they're going to get it. It will be reimbursed. If it was a Part B drug, they would be reimbursed for the physician-controlled product distribution at the rates of a Part B drug. If it's Part D, it's under the Part D network.
I want to thank each one of you for being here. I mean, I know we're out of time, but to thank you for each. We're going to have more meetings, and Mr. Ranking Member Comer, thank you for holding this.
Well, thank you, Mr. Norman, and I tell you, that's a lot of information in 2 hours. I think this was a very productive hearing, very efficient hearing. I want to thank all the witnesses who came here. This isn't the end of this. This is just the beginning. We sincerely want to provide oversight. We want to provide solutions to the problems to end waste, fraud, and abuse in government. One of the problems with abuse and waste in government is excessive, unnecessary bureaucracies. I want to thank Mr. Caldwell for being here today. We really appreciate it. This was a very informative hearing. I'm sure there's nothing that was spoken here today that you haven't heard in the past. I mean, with all due respect, PBMs are less popular than Kamala Harris right now. You know, I mean, it's a problem. It's a problem out there. Healthcare is one of the biggest issues in America right now. So it does a disservice to this institution to hold hearings on prescription drug pricing and not include PBMs, because that's a major factor in pricing. Then you have the other issues that have been spoken today, and I've heard from many independent pharmacies where they have customers that they've had for years and years and years. The PBMs have access to their data, and their customers start getting invitations and solicitations to, instead of going to that brick and mortar store, to do mail order pharmacy for the same prescription that they've been purchasing from that pharmacy. So they have to be getting that information from a private business. I mean, there's so many rules and laws that need to be examined here, and we're going to issue a report. We invite everyone that testified today to continue to communicate with this committee. As was said at the beginning of this hearing, I think communication is a huge problem between the stakeholders and the PBM. So we certainly support the private sector. We certainly do not frown upon making a profit. But at the same time, when we examine healthcare in America, the fact that Americans pay a higher cost for prescription drugs than any other country, and PBMs play such a major role in that, I think it's something that Congress needs to address, and I think it's something that shouldn't be as complicated, Dr. Trish, as it is. I mean, you're the expert, very educated, and you can't, have a complete understanding of the formula. So we need more transparency. We need to reform this, and I think we can, and we're going to work with every committee of jurisdiction on this issue moving forward. And again, this is a preview of what the Oversight Committee is going to be doing and conducting this type of oversight moving forward, and I believe that we'll play a major role in this Congress and hopefully reducing waste, fraud, abuse in the federal government. Again, Mr. Norman, thank you, and thank all the members who participated in the panel, and thank the panelists. We are adjourned.